here. It's my honor to welcome my mentor, my teacher, my guru, Professor Neelam Pushkar ma'am, for her talk that is on cutting edge technique in eyelid restoration. Thank you, ma'am.
Thank you, Manu. Good morning once again. So, I'll be talking about the advanced techniques in the eyelid restoration. So, eyelid deformities, varied, types of deformities we come across like coloboma, retraction, notch, contour deformity, ectropion, entropion. So if you see the common causes, generally we see either congenital, like in this girl with the tasier cleft and with ocular anomaly and the lid which is not in position. And acquired causes, mostly we come across are the iatrogenic, which is following the excision of the malignant tumor, and then following some kind of injury, the patient can have, lid deformity. So some difficult cases I am showing here. Now, why I am saying difficult, generally mild to moderate severity of lid deformity, generally we have good outcome, aesthetic, functional, etc. But if there are, periorbital fracture or depressed, periorbital tissues, lot of scarring and the loss of the, the lid structure, it becomes very difficult to really give them good functional and aesthetic appearance. So my focus in this talk would be on single stage procedures, even for severe deformities and large colobomas. So why I'm emphasizing this is because traditionally we've been doing, procedures where generally it's a lid sharing procedure or something where it becomes like a two-stage procedure. But if we have the knowledge of the single stage procedure, we will always keep them in our mind so that we can, apply it depending on the need of the patient. So why single stage procedure I am emphasizing here, because we all know that it will avoid the second surgery. Early recovery will be there. It will reduce the financial burden, and now we have, sufficient literature also on the single stage procedure. So it's important that we have knowledge of these, at least the knowledge of the principles of these procedures. So traditionally, these are the flaps we've been doing, like Blasius flap, where we can rotate from the area in between the nose and the cheek, as shown in the picture over here. Can I have the pointer, please? So, or Mustardi's cheek rotation, like in this particular patient, you can see this is the Mustardi's outcome. So, these are the well-known procedures. But it's important that we go on to some newer techniques also. This is a novel modification of sandwich technique, which was published by me. So, what was novel about this? So sandwich technique was described way back in 2008, and in this what the authors did was they took a block of full thickness eyelid from the normal eyelid, as you can see over picture here. So from here the block was taken. So generally this was described for mild to moderate, full thickness defect. And then it was taken and filled in this area. But we know that full thickness or a composite graft will not survive until unless it has a base of, vascular tissue within it. So what authors did were they took out the orbicularis from between this block of the lid, this pink thing, and then this was taken out, and this particular area was sandwiched with the orbicularis muscle, which was advanced from the recipient bed, which was a vascular tissue. So this is how the whole block of the eyelid will survive along with the cilia. Results were good. So using the same principle of sandwich technique, I went ahead with the use of composite graft taken from the posterior surface of the ear, which is a routine site of our surgery. So it was taken, the cartilage and the skin, depending on the size of the defect, and then it was placed like this. This is the cartilage which was left bare, and it was sutured superiorly and inferiorly with the conjunctiva, and this is the skin over here. Now this particular block will not survive until unless we have a vascular bed. So the vascular bed was taken with the help of advancement of the surrounding recipient orbicularis tissue. So this was then published in 4 patients. These are some intraoperative picture. I'll show the video. So what happened? It's not running. All right, so this was a patient with icicle eye with upper lid coloboma, which was deep enough, and there was inferior lid symblepharon. So coming to the preparation of the bed, because the aim was to fit artificial eye and restore the upper lid coloboma tissue also. So after the symblepharon release, the amniotic membrane was placed. So in this particular technique, where I use the cartilage, I have modified this as that I place the cartilage always around 5 to 6 mm away from the so-called lid margin or the colobomatous edge. So this is mainly because the cartilage will not rub the cornea and we will not have all those issues where the cartilage is directly, sutured. So coming to the ear side, I mark it. Now I have stopped doing the marking anteriorly, but this is my initial video. So this is from the scapha of the ear, which has more, convex tissue, the cartilage, and it conforms nicely with the shape of the eyeball. So I avoid taking from the concha, I take out from the scapha. So externally, I have marked it so that I am not lost during the surgery where exactly is the scapha. So this is how you can mark in the initial stages of your surgery. And then going to the posterior surface of the ear, so depending on how much skin I want, so I mark, and then later on how much cartilage I want, I take out. So here I am incising the skin all around. And after that, I'm going to the, cartilage surface. And this undermining is also very important. So once I see that, I give a partial thickness cut, not full thickness, because we don't want the skin to get damaged. So after that, very carefully, I make it full thickness. So you can see this is the cartilage with its perichondrium. And then without, disturbing the skin anteriorly, I'm taking out the desired amount of cartilage along with the skin as a whole block. Now, recently I've stopped taking out as a whole block. I take out skin separately and the cartilage separately. So this is just to, prevent any hematoma collection in that particular area. So if you preserve the helix until helix, then the, as such, the deformity of the ear is avoided. And you can see that nicely it is fitting. So now from the conjunctival, whatever conjunctival edge I have, inferiorly I am suturing with the cartilage graft, taking out partial thickness so that there is no tilting of the cartilage. So that is an important point I want to highlight in the surgical technique. Then superiorly, luckily, I could take out the, the LPS, I could see where it is, and, directly inserted the LPS to the surface of the cartilage. So in these patients, the cartilage surface is bare. It's not covered by the conjunctiva. So it's basically augmenting the posterior lamella also. So you can use this in any kind of deformity where you want to augment both anterior and posterior lamella, provided you have a healthy, orbicularis tissue all around. And after suturing the skin, now this in-between tissue you need to remove because you want to place the recipient orbicularis in between the skin and the cartilage. So this is the orbicularis I have mobilized from the upper part. You can see around 8 mm orbicularis band I have taken, and like a hammock, so that we have the vascularity in the muscle also. So like a hammock, I am mobilizing it and placing it over the cartilage, covering the cartilage, so that, overlying skin nicely comes over it. So just 1 or 2 suture, 8-vicary suture, just so that it, doesn't retract back. Then you take out bite from the LPS also, so that you have a lid crease, lid fold, and then you close it completely. And because LPS I could find, so you can see the movement and the lid crease, lid fold. And this is the post-op picture with the artificial eye, where he could use artificial eye properly, well placed. So these are some of the cases where skin cartilage graft was used to correct these deformities. So you can see the pre-op picture on the left side, and on the right side you can see that the notch has gone. And in the lower gaze, if you see, there is a skin graft over there. So I keep the skin graft as well as the cartilage away from whatever edge is available with us. This is just to show the limitations. CAFA is limited. Around 7-8 mm you can safely take out, otherwise there will be ear deformity. So this patient had, I had to cover almost 12-15 mm of the sclera, so that was not possible in one sitting. So second sitting, the surgery is awaited. But you can see 50% it has been corrected using skin cartilage graft. Then this patient was one-eyed patient with lower lid coloboma, as you can see. And so you can see on your right side early post-op picture, and lower down you can see that there is a late post-op picture, and there was no leg of ophthalmos. Now, another patient with shallow, large coloboma, you can see more than 50% coloboma is there. So in this, again, the skin grafting post-op, you can see skin cartilage graft used. But there is, slight flattening you can see in the center part of it. So when I saw there was a, fistula which was there because of the wound dehiscence. So he was operated again after 6 months of the surgery. So this is another patient where there was severe trauma, multiple surgeries, and even I did cutler beard surgery, but the lower lid was, it was sagging down. So you can see after the skin cartilage graft, 6 months later, the lower lid is resting at almost, covering the limbus. This patient, multiple surgeries done, including mucosal graft, but the lower lid was not forming, was not supporting the artificial eye. So this is after the skin cartilage graft. You can see the post-op picture with the artificial eye. This patient, very interesting, operated almost 10 times elsewhere. There was entropion in the upper lid, badly traumatized, even absent, tarsus, and the lid was also very irregular. And in this patient, I had placed only cartilage graft, and I did anterior lamellar repositioning technique to correct the entropion. So she developed pyogenic granuloma, which was then later on excised. You can see over here, this is the pyogenic granuloma. It was excised, and this is the late picture where the entropion at least is corrected, though the lid is not looking very good, but then it was already operated multiple times, already deformed. And this patient, this I guess I've already shown. Then coming to another important principle is of eyelid skin flap. Again, this helps in single stage surgery. So what exactly is eyelid flap is when you take out, incise the skin all around circumferentially, and you leave a subcutaneous pedicle for the vascularity. So it is like a flap. And this is a very interesting, series of patients reported by Razak et al. And you can see how the skin was taken along with the pedicle. This is the pedicle over here, if you can see, which was retained, and this provided the vascularity, and a graft was used for the posterior lamellar reconstruction. So any location of the, large defect, this surgery they had described. So using the same principle, I did in this patient with a lower lid basal cell carcinoma, where there was a large defect there, and then the skin was incised all around, and then this was then rotated. This is the pedicle which was there, and the skin was closed later on, and this was placed. I'll show the video of this, a very short video, where you can see how it was rotated. So this was the lower lid BCC, biopsy proven, and this is just a marking, and a frozen was also done in this. So this included the upper lid also. So after removal, I took a, I did the undermining just so that the things are relaxed, and the marking of the eyelid flap was done, and Hughes flap was raised from the upper lid. To keep the surgery short, in this I decided to do a two-stage procedure. Though with the eyelid flap, you can just do a single stage and use a graft for the posterior lamellar reconstruction. But this patient was having multiple systemic issues, and I had to, finish the surgery quickly. So, so this is how it was incised. The skin is incised all around. Rotation becomes very easy. and there is a subcutaneous pedicle, but you cannot rotate beyond 180 degree, otherwise the vascularity will be all gone. So fixing of the graft is done even with the upper edge is fixed so that it doesn't retract. So just taking a partial thickness bite, and this was the, picture over here. Then this is another novel technique which I had described for moderate to large defects, and I published this. This is a lateral eyelid rotation flap. The beauty of this technique is that the full thickness lid is rotated from the opposing normal lid, and it has its lid margin with cilia and everything. This was also published, and you should try to read this and try to understand that in this particular this thing, the main limitation which we have in moderate to large defect when we repair them using any technique, the lid margin structures are not there. But with this technique, the lid margin structures are there, but the prerequisite is that you should have the lateral, canthal tissue in the site where the coloboma is. So in this, the rotation was done. I'll show you the intra-op picture. You can see there is almost 50% defect, and how the flap was taken throughout with some pedicle which is still attached. The only important thing is that you have to cut the septum throughout, which is a little blind procedure because you just put the instrument inside and cut it, but rest has to be attached. So the vascularity is not affected, and this is a video showing the technique. It's again not running. Can you start the video, please?
Anybody from the audiovisual team, please come forward.
Yeah, okay, it started now. Thank you. So this is a large sebaceous cell carcinoma. So though it looks small, but you see the size of the defect. Hardly any lateral canthal tissue available in the, colobomatous lid. So it's a deep coloboma. Now from the opposing lid, we have to take out full thickness lid along the orbital rim and equidistance all through. And when we are cutting going in the superior side, we don't have to go to the fornix because there the ductules are there, we don't want to damage that. So full thickness cut or 6 mm was kept standard by me from the lateral canthal 6 mm. This is the lateral canthal ligament which I am cutting, but a suture has been passed. So here we have to see that it has to be equidistant from the, from the lid margin throughout, including the lateral canthal area. So the lid, if you see, it appears that probably it will not close. The only thing is that on table it becomes tight, but everything is in place later on during the follow-up. So this is the coloboma which I am, passing the sutures from. I've already passed from the lateral canthus just to align everything and see the tightness and correction of the thing. Now the lateral canthus I am tightening, and then coming to the, now you can see that it's almost, the whole thing is, filled. But the main thing is that because it's a rotation from the lower lid, there is a nice, dog ear which we have to remove to properly align the whole lid. So here I am forming the lateral canthus suture, passing out from the gray line so that there is a direct and correct apposition at the lateral canthus also. You can see how much the lid has been corrected, almost 26 mm. And then after that, I do rest of the suturing, apposition, wherever excess tissue is there, I cut that. And this step is very important. This is done at the level of the lateral canthus, sparing the lid margin. We are not cutting the lid margin, and only we are taking out the skin muscle, not going to the posterior lamella. We have to maintain the vascularity. So none of the patients in the series, had any kind of necrosis or any problem, but tightness was definitely there. And this is on your right-hand side, you can see all these 3 patients, the left eye has been operated. So you can see all the, structures are well maintained. Minor issues are there, but we expect all that in, large colobomas and severe patients with severe deformity. So take-home message is that we should try to expand our knowledge as far as the lid reconstruction procedures are concerned. It's very important. And we have to apply our knowledge depending on which varies from patient to patient. So it is like a tailor approach which we have to keep in mind. Thank you so much.
Thank you so much, ma'am, for sharing such a beautiful videos and sharing the complicated severe lamellar loss devastated cases. And it provides a novel avenue for us and everybody to learn them. Any comments from the audience and from the panelists?
Thank you, ma'am.